Good morning, everyone, or wherever you are, whatever time it is. It is morning here in Halifax, Canada, where I am Assistant Professor of Neuro-Ophthalmology and Adults for Business. Today is going to be a very basic review of cranial nerves 3, 4, and 6. It'll be mostly anatomy focused and basically helping you localize the lesion. But there will be a little bit of time for questions, and I will go over some more common etiologies that I see. It will be very different from what you see probably where you are, but that doesn't change the fact that the best way to figure out an etiology or determine what the next step for blood work or testing is going to be dependent on your history taking. So we will get started. I do not have any financial disclosures or conflicts of interest at all, let alone related to this talk. So I can't talk about the cranial nerves without reviewing the anatomy, but let's first review the anatomy of the extraocular muscles, which the cranial nerves innervate. So in order to achieve extraocular motility, you have these 6 extraocular muscles. The easiest ones to start with are the horizontal muscles, so the medial rectus and the lateral rectus. They only have one primary function. Medial rectus adducts the eye towards the nose. The lateral rectus abducts the eye towards the temple. Then you get into the inferior and the superior rectus muscles, which do the vertical aspects of eye movement, but they also have secondary and tertiary functions. So the secondary function is just a little bit more than the tertiary function, but their main function, the inferior rectus depresses the eye and the superior rectus elevates the eye. They just have mild, very, very mild torsional components, and the abduction and the adduction that they both do is also very, very minimal. And then, of course, you get into the inferior oblique and the superior oblique, which are the fun ones. Inferior oblique being where it is, you can imagine as it pulls, it will excyclotort the eye, and the superior oblique being where it is through the trochlea and then attaches to the eye underneath the superior rectus muscle would intort the eye when it contracts. They also have some role in the elevation and depression, so they are responsible a little bit for the vertical movements and very, very mildly with abduction. The innervation for these muscles is fairly easy to remember if you have this little mnemonic. So basically LR6SO4 means that the lateral rectus is innervated by the abducens nerve or cranial nerve 6, and the superior oblique is innervated by cranial nerve number 4. 3 does everything else, including the eyelid and the pupil. This is a great anatomy diagram that overviews all the cranial nerves and their relationship to each other. So I always reference back to this diagram when I'm trying to think about where the cranial nerves are. It's also important to think about where all the cranial nerves are all together. If you have multiple cranial nerves, we will touch on that later in the talk. But not only that, I like this diagram because it also shows the relationship between the cranial nerves in relation to other structures in the brain, such as the blood vessels. So you see in this diagram here, you've got all the cranial nerves coming out, and it's got the orbit and the eye there, but it's also got the bones and importantly, the blood vessels that can cause problems sometimes. So this is a nice overview. You can see where everything originates. I'm just going to put a laser pointer here. So you have cranial nerve 3 and 4 up in the midbrain and cranial nerve 6 in the pons, along with the trigeminal nerve and such. We will not be talking about the other cranial nerves. We'll just briefly mention them, but the main focus will be cranial nerve 3, 4, and 6. So to jump right into the anatomy, the oculomotor nerve or cranial nerve 3 has a fairly large nucleus in the midbrain, and each section of the nucleus is responsible for a different function. Generally speaking, as it exits the midbrain, it will pass between the SCA, which will be below it, and then the PCA, which is above it. And then it will run obliquely to the tentorial edge and parallel and lateral to the posterior communicating artery. This becomes important because the pupillary fibers are usually on the dorsal medial side of the nerve, which means that if there was any issue with the posterior communicating artery here, like it had an aneurysm, for example, you would be pushing on these pupillary fibers. And these pupillary fibers, you would then end up with a large pupil. So I like this diagram because it shows cranial nerve 3 here just as it exits, and you can see it exits between two blood vessels, two arteries, and then courses along beside another artery before going into its dural canal. The other thing that is interesting about cranial nerve 3 in this position is that it is also vulnerable to compression by uncal herniations. What does uncal herniation mean? It means that the most medial aspect of the temporal lobe, which is not shown in this diagram because it would become too messy, but basically this medial aspect of the temporal lobe gets forced through the tentorial notch to push on the cranial nerve 3 because there's a mass above it supratentorially causing that downward pressure. This again would also cause a blown pupil because again, the pupillary fibers are dorsal medial in this area. After it enters its dural canal at the back edge here in the dura of the clivus, like right above cranial nerve 4, it then runs in the superior lateral wall of the cavernous sinus before it separates into the superior and inferior divisions and then enters the orbit to innervate basically everything except for the lateral rectus and the superior oblique. This is a good diagram to summarize in a schematic form the course of the cranial nerve 3 and all the different locations that you can have a lesion that would cause a problem with cranial nerve 3. So you have either a nuclear lesion, which we will not go into, but just know that the anatomy is a very important, fundamental, basic knowledge that you need to know when you think about cranial nerve 3 to see where all the possible locations of the lesion can be. Moving on from cranial nerve 3, we'll touch on cranial nerve 4 now. So cranial nerve 4 is unique because its nucleus is in the midbrain, just below the aqueduct, but it decussates, so it crosses before it exits. And the other interesting thing is it's the only cranial nerve that actually exits on the dorsal surface of the brainstem, where others will exit ventrally, like you saw in cranial nerve 3. The other thing about it is that it is the longest and thinnest, and also it's got the longest unprotected intracranial course, which makes it vulnerable to closed head trauma. So you see as it exits here, it's in free subarachnoid space and is not protected by any other surrounding structures, which is why you end up getting a cranial nerve 4 palsy most commonly when you have closed head trauma. It doesn't even have to be massive trauma. It can be something that can cause a concussion, and some people will end up with a cranial nerve 4 palsy. After this, it swings around the midbrain, and then it will parallel the tentorium just under the tentorial ridge, or the edge, sorry. And so if you see from this diagram, when I was focusing on cranial nerve 3, cranial nerve 4 is right, where is it? That one's, yeah, right here. This thin, teeny tiny, small one as it keeps going. And because of that, it's just under the tentorial edge. So any sort of neurosurgical procedure that involves the tentorium can potentially damage the cranial nerve 4. And so in that case, you would get an iatrogenic cause of cranial nerve 4 palsy if they dinged the tentorium and hit the cranial nerve 4. After that, it then enters in the posterior lateral aspect of the cavernous sinus, right underneath cranial nerve 3, and then goes into the orbit after that. And again, this is a good diagram to summarize basically all the possible places that you can get a cranial nerve 4 palsy, where the lesion could be, with the subarachnoid space being probably the most common one because it is unprotected there. Okay, and last but not least, the abducens nerve, cranial nerve number 6. So its nucleus is in the dorsal caudal pons, and it is surrounded, like literally hugged by the looping fibers of cranial nerve 7, which is the facial nerve. So the 7th cranial nerve has its nucleus just around where cranial nerve 6 is, the nucleus as well, and its fibers kind of wrap around before they exit. Cranial nerve 6 then runs within the subarachnoid space along the clivus, and then enters the dura about 1 centimeter below the petrous apex, so that's a bony structure, and then will travel beneath the petroclinoid ligament, also known as Gruber's ligament. It's a ligament that connects the petrous pyramid to the posterior clinoid. After that, it then goes into the inferior petrosal sinus and exits the dura into the cavernous sinus. And it's the only cranial nerve that is actually in the stuff of the cavernous sinus. If you remember in the cavernous sinus, the diagram, most of the cranial nerves are all off to the side. Cranial nerve 6 is the only one that is in the cavernous sinus, and it's right beside the ICA, so the internal carotid artery, and then enters the orbit through the superior orbital fissure. Now, a question that comes up all the time is, but why is it cranial nerve 6 that is the one that is most vulnerable, and you get a cranial nerve 6 palsy when you have elevated intracranial pressure? And that has to do with its anatomy. So you see here, it's vulnerable in this area right between the brainstem and the clivus in the subarachnoid space. And as it enters Dorello's canal, sometimes it gets a little bit tethered there so that it keeps going on its natural course. What happens in elevated ICP when you have high pressure in the brain from whatever reason is sometimes the brainstem kind of gets pushed downwards, and when it gets pushed downwards, there's stretching of the cranial nerve 6, which is why you get cranial nerve 6 palsy when you have high pressure in the brain. So that's the review of the anatomy. I can show you this again if there are questions at the end asking for it to be shown again. But the anatomy is very important, and always go back to basics to your anatomy if you're confronted with a nerve palsy and you don't know where to localize. Now, we've talked about the nerves. What happens when there's a nerve palsy? So if there's a lesion somewhere in the nerve that's causing a problem, how does that present clinically? The things you need to ask about are to screen for all of these possible etiologies, okay? I'm not going to go in detail because I assume that with the audience being mostly a staffed ophthalmologist or neurologist, you know how to take a history. You know how to ask about associated symptoms. You know how to examine that, if there's more than one cranial nerve involved, you know where that would localize to. But generally speaking, fall back on these possible etiologies. Some people use the mnemonic vitamin C and D to go through, V stands for vitamin, I stands for ischemic, and they go through all the possible etiologies like that, which is always a great fallback as well if you're trying to think about what is causing this patient's cranial nerve palsy. The other thing that's important is while you're taking history, don't forget about the patient's general health and their medications, and if they've ever had any trauma or any neurosurgical procedures or anything like that. And so history is very important. In terms of infectious causes will vary from place to place, but anything that can hit the brain can potentially affect a cranial nerve. And any history of neoplasm in the body potentially can metastasize to the brain. And also don't forget that we can cause problems, especially if you're tinkering around in the brain iatrogenically and causing neurosurgery, usually causing problems. And sometimes you can't help that, right? Sometimes cranial nerves need to be sacrificed during the surgery. And so never forget that a good history will usually point to the most likely etiology, which then will guide your investigations. Cranial nerve 3 palsy. So we talked about how cranial nerve 3 basically innervates everything except for the lateral rectus or in the superior oblique, which means that when it is not working, your eyelid comes down because you got no more innervation for something to keep the eyelid up. And you get an exotropia because the lateral rectus is functioning just fine and it's pulling because that's innervated by cranial nerve 6. And you get a hypotropia because the superior oblique has a small vertical component and keeps the eye a little bit up. And so if you don't have cranial nerve 3 working, everything else doesn't work, you will get a ptosis, an exotropia, a hypotropia, so the eye is down and out, and you may or may not get pupil involvement if the pupillary fibers are involved. This is a good diagram with the 9 gaze showing this. You see in primary, there is a left ptosis. There is a positive thumb sign in the photograph, meaning that the eyelid has to be held up by the examiner. Abduction of that eye, no problem. No adduction, no elevation, and not a lot of inferior down gaze depression either. And so classic presentation of a cranial nerve 3 palsy. You can't see the pupils in this diagram, and so a good pupil examination is important. And if there is major anisocoria, so if there is a very big pupil on the left side compared to the right side, you would suspect that there is pupil involving cranial nerve 3 palsy, and that is important. Why is it important? Because it helps you make your decision for whether or not you do imaging. This is a very basic, and for me, I like to think about cranial nerve 3 palsy and when I need to get neuroimaging with this diagram. I first think, is the cranial nerve 3 palsy complete or is it partial? If it's partial, I'm getting imaging. I'm getting a CT, CTA, or an MR, MRA, or in some parts of the world, if you need to get angiography, you get angiography for this. You're screening for the PCOM aneurysm or any sort of blood vessel abnormality, because remember where the cranial nerve 3 exits in the brain. Is there aberrant regeneration? Yes, I'm getting imaging. I don't care. It's compressive until proven otherwise, okay? So these are the 2 situations where it's compressive until proven otherwise by neuroimaging. If it's complete, you can have some time. If it's complete and it involves the pupil, those pupillary fibers, like I said, are vulnerable to either uncal herniation or the aneurysm in the PCOM, you're getting imaging right away. If it spares the pupil, you have time to observe. In my experience, everyone gets imaging for cranial nerve 3 palsy anyway. The difference is if it's pupil sparing, you have time. You have time to schedule the imaging. It doesn't have to be urgent or semi-urgent like in these cases, okay? Pupil sparing complete. So the eyelid is completely down. It's completely down and out. The pupil is not involved. You can observe. If eventually it's pupil sparing at first, you still need to follow these people. It becomes pupil involving, you're getting imaging right away. But if it never involves the pupil, you are okay to observe unless and get imaging to wait to get imaging when either the pupil gets involved or it's not resolving. This is an example of a 9-gaze composite photograph of someone who has a cranial nerve 3 palsy but has aberrant regeneration. You need to get urgent CTA or MRA head to screen for either the posterior communicating aneurysm, a compressive lesion, or if there's any history of major trauma. The reason being is there is now evidence that cranial nerve 3 has been affected by likely a compressive or a traumatic etiology and has already regrown to the wrong targets. So in this case, you see there isn't a ton of ptosis, okay? So you wouldn't even suspect that it's a cranial nerve 3 palsy until they look down. What is your eyelid supposed to do when you look downwards? The eyelid is supposed to come down with your eye when you look downwards, okay? If you look at someone looking down, you notice their eyelids also come down, right? In this case, there is a left cranial nerve 3 palsy that has now had aberrant regeneration. because there are fibers now that are innervating. When you look down, the eyelid comes up instead. So there is aberrant regeneration to the eyelid. And I think there is also aberrant regeneration. Yes, there is aberrant regeneration in elevation here in this photo. The medial rectus is also involved. So we have muscle to muscle and we have muscle to eyelid aberrant regeneration here. This is concerning. If there is no history that you know of trauma, and you don't know whether or not there's compressive etiology, you need to image to rule those out. Okay? Cranial nerve 4 palsy. It's always the tough one with the Parkes 3-step test. So this is to review, how do you find a cranial nerve 4 palsy using Parkes 3-step test? Like I said, if there's a cranial nerve 4 palsy, usually it causes the eye to be higher, right? So the first step is, which eye is the higher one in primary position, okay? The impacted muscle will either be the depressor of the higher eye or the elevator of the lower eye. So in your diagram, those are the things that you circle. I will get to that in a second. Once you've determined which eye is the higher one, you need to see, does it get worse in right or left gaze? Does the higher eye get higher in left gaze or in right gaze? If it's in left gaze, then it's the superior oblique in the right eye or the superior rectus in the left eye that is affected. So you circle over there in the left side, okay? If it's the right side that's affected when it's worse looking to the right, then you circle the superior oblique in the left eye or the superior rectus in the right eye. Circle those ones, okay? And finally, is the hypertropia worse in left head tilt or right head tilt? If it's worse in right head tilt, the right eye intorters, the superior oblique or the superior rectus, or the left eye extorters, inferior oblique and inferior rectus, are affected. So you circle this way. And then if it's worse in left head tilt, it's the left eye intorters or the right eye extorters. So you circle that way. Okay. Ultimately, I think this diagram does a very good job of it. You will end up with the superior oblique, or if you don't, you end up with another muscle that's circled 3 times, but that is how you find out where the problem is when you are dealing with vertical deviations, okay? I encourage you to look at this website and go through it again, the iwiki.org, the 3-step test. Really comb through it and try to understand it. I do know that for beginning learners, the first step that's important is figuring out which eye is higher, and then figuring out circling the correct ones for these ones. And then the cheat after that is, if it is worse in left gaze, you circle the ones on the left side. And if it's worse in right tilt, then you just circle the ones tilting to the right this way. Okay. But it's better to also understand the concept. But if you're in a pinch for time, make sure you get the first step right. And then the other steps are a little easier. Just if it's worse in right gaze, then you circle the right ones. If it's worse in left gaze, you circle the left ones. And then for tilt, if it's worse in right tilt, then you circle this tilt to the right. And if it's worse in left tilt, you circle the tilt this way to the left. Okay? Don't tell anyone I told you that. Like I said before, it is the longest and thinnest of the cranial nerves. And so because of that, it is most susceptible to trauma. And like I said, it doesn't even have to be major trauma. But also it is one of the ones that are more commonly congenital. And so you can have a congenital cranial nerve 4 palsy and not really notice until later on in life, and it can decompensate. Okay, so people don't get double vision for most of their life from their congenital cranial nerve 4 palsy, and they will either have an illness or it just decompensates over time. Clues to telling you that it is long-standing or congenital: look at their old photographs, okay? Ask them to bring in some photo albums from when they were children or teenagers, and you can almost see when they started to get the nerve palsy. Children who have congenital cranial nerve 4 palsy and grow up with it don't have double vision because they compensate for it very well with large fusional amplitudes. The vertical fusional amplitudes are large. So I've definitely seen people who are adults and then suddenly get double vision, but when you check their vertical fusional amplitudes, they're like 6. which is not normal. And the only way that that can be is if they had it for a very long time, usually within childhood. Because of the long-standing head tilt to one side, what happens is gravity causes some changes to that side of the face that's down. So when you finally straighten them out, you'll also notice that they have a little bit of facial asymmetry. And so these are the three clues that can tell you that it's probably long-standing and that you don't need to do any sort of neuroimaging urgently for them. However, if it suddenly becomes acute and there is no documented history of trauma to the head, then I would probably get an MRI brain with contrast. It's best when you are talking to neuroradiology or radiology that you're ordering this test because you're looking specifically at cranial nerve 4 so that they know how to get, they know which sequences to get the best to image the cranial nerve 4. Cranial nerve 6 palsy. So this one's fairly easy. You get an abduction deficit. So you see in this diagram here, the left eye is not abducting, and it doesn't matter if it's in up or down, it doesn't abduct, whereas the abduction towards the right is normal. And so generally speaking, neuroimaging is recommended if the patient is younger than 50, if there's associated pain or other neurologic symptoms, if there's a history of cancer, if it's bilateral, if any of the other cranial nerves are involved, or if it doesn't go away after 3 months, you're thinking about getting imaging. If they have papilledema on examination, or they're complaining of symptoms of elevated intracranial pressure, so things like headache, nausea and vomiting, pulsatile tinnitus, transient visual obscurations, diplopia from their cranial nerve 6 palsy, all those together indicate maybe they have high pressure in the brain and you should get an urgent CT venogram or MR venogram, depending on what you have available to you. The reason for the venogram is you're also screening for a venous sinus thrombosis, which can cause elevated brain pressures. Generally speaking, you just need to image these people if there's something unusual about it or any of these criteria come up. Okay, I know this is not a cranial nerve, but it relates to two cranial nerves that need to talk to each other, okay? So have you ever wondered that when you look to the right or when you look to the left, you are utilizing one lateral rectus to move the eye, to move one eye the other way, and one medial rectus to move the eye in the same direction? The reason it can do that is because there is a connection. There's an internuclear connection, a connection between the nucleus of cranial nerve 6 and 3 that coordinates this movement so that you can look to the left or look to the right. You can look side to side at the same time, okay? And this connection happens through the medial longitudinal fasciculus, the MLF, right here. So you have cranial nerve 6 here, cranial nerve 3 here, and they talk to each other through this bundle, this highway. So when you need to look to the left, there's a connection here so that the eyes both move together. But what happens if you get a lesion in the MLF? Well, they can't move together anymore, and that's when you get an internuclear ophthalmoplegia. Internuclear meaning because there's a problem between the two nucleus, the communication between them is not good, and the ophthalmoplegia meaning because of this, it's not moving together, okay? Classically on examination, what you get is you have an adduction deficit. So say the medial rectus just doesn't go when you're trying to go this way. And you get a contralateral abducting nystagmus. So there's beating nystagmus and the eye can't adduct. One eye cannot adduct, the other one is just beating with nystagmus. The most common etiologies for internuclear ophthalmoplegia, generally speaking, is in a younger patient. It's usually demyelination in my part of the world. And stroke is more likely in the older patients in my part of the world. To me, when I see an internuclear ophthalmoplegia, it doesn't matter if they're young or old, I'm getting an MRI. If they're old, I might be getting a CT or CTA or angiography, like I need some sort of blood vessel testing because stroke is most likely. So I'm looking for a stroke in the blood vessels. Is there occlusion somewhere? And so the MRI brain with contrast achieves that, but in a pinch, the MRI brain is good for the demyelination because you find the white matter lesions. And then the CT scan in a pinch, if you can't get an MRI urgently, is also okay for stroke because you can get a CT, CTA, head and neck for that. Okay, I said I would talk about multiple cranial nerves. It all comes down again, back to where we started, the anatomy. So think about where the cranial nerves all come together and if they have other symptoms, okay? If more than one is involved, you have to think about where it localized, right? So anatomically, for example, you know that 3, 4, 5, and 6, if all of them are somehow involved, it's either going to be at the cavernous sinus or at the orbital apex if cranial nerve 2 is involved. So if they have vision loss and they have all these other things as well, you're thinking either orbital apex or the cranial nerves only, then it's probably cavernous sinus, okay? Remember 6 and 7, like if you have an abduction deficit and you also have a facial palsy, that can only really be in the pons and by the cerebropontine angle, because that's the only place where the two of them are together. And so it is more likely for one thing to hit two things together. So if they're close together, so don't think about where they're, anatomically separately, but where are they the closest together? And so this will then help your radiologist localize the lesion much better if you tell them exactly where you're looking for a lesion. Okay, so most of this was focusing on the anatomy because it was mostly looking at compressive etiologies. Where I am, I also see a lot of ischemic microvascular cranial nerve palsy, and because of where I am also, I also see a lot of vasculitic. That doesn't mean that any of these are not possible, but these are found out by history, okay? And so for infectious here in Nova Scotia, I tend to actually order a lot of Lyme serology because Lyme is endemic here, but this could be very different for someone else in another part of the world. TB, for example, would be a common cause potentially somewhere else. I do also test for TB here because we do have a lot of newcomers coming to the country as well. So Lyme, TB, or any of the viral infections, sometimes I'll think about as well. But again, history, right? And the examination, are they febrile? Do they have any other issues? And so there's that. Traumatic's pretty obvious. Usually they're in the ICU or something with a big trauma, and then demyelinating, infiltrative, neoplastic, iatrogenic, again, history. I'm just going to briefly touch on these two etiologies, ischemic and vasculitic, just because for me, they're most common. They might not be for you though, but I think universally ischemic is pretty common. So a microvascular ischemic nerve palsy tends to happen in the patients who have poorly controlled vascular risk factors. And so that means they have diabetes, they have high blood pressure, they have high cholesterol, they have an unhealthy lifestyle, they're obese. You know what this person looks like, right? And so if they come in with a cranial nerve palsy, most likely than not, it's probably this, but you still need to do your exam, right? You still need to do your due diligence. Make sure, is there any more cranial nerves involved? Sometimes microvascular nerve palsies can be a little bit painful. And so they're aching. It's kind of like an aching pain. And classically, they should resolve in 2 to 3 months. And if they're not resolving in 2 to 3 months or not even getting better or starting to get better, then you have to worry about it not being microvascular. And this is when you need to start thinking like all the other etiologies, review your history again. Did I get neuroimaging? You should probably get neuroimaging if it doesn't resolve in 2 to 3 months. And then the other important part is you need to collaborate with the patient's general practitioner, their family physician, to make sure that you get the help that they need. They need vascular risk factor modification. They need to control their diabetes. They need to bring down their cholesterol. They need to quit smoking. You need help for this. And so it's a collaboration with the patient's other health providers as well. So when the microvascular nerve palsy happens, usually it's a sign that they're having trouble with one of these things. And so you need to talk to their family physician to help them with that. I see giant cell arteritis a lot here. In Nova Scotia, our population is older, and we're mostly white in this part of the country here. And so, as you know, giant cell arteritis, if you don't see it very much in your part of the world, I think that's good. But in my part of the world, I see it quite a lot. It is the most common primary vasculitis in the older population. The median age is 75, and I think about giant cell arteritis in anyone that's older than like 60. As you know, on pathology, it's a granulomatous inflammation of any of the medium to large size vessels, and classically they'll have headaches, PMR symptoms, or joint pains that are getting worse, scalp tenderness, jaw claudication, they're losing weight, they don't look good, they don't feel good. And I know we always think about giant cell arteritis when there's, the transient monocular vision loss. There's an arteritic CRAO or an arteritic anterior ischemic optic neuropathy. But don't forget, the cranial nerves also need to be supplied by some of these, medium-sized blood vessels, and you can get cranial nerve palsies with giant cell arteritis. And so I have a low threshold of suspicion in someone who's like, say, 70 and doesn't really have much in the way of vascular risk factors, like they've been healthy for most of their life, and all of a sudden they get like a cranial nerve 6 palsy or a cranial nerve 4 palsy or cranial nerve 3 palsy even. I have a low threshold of asking about all these symptoms, and if they have a few of them, I'm still testing them for ESR, CRP, CBC, checking for platelets to see if they have elevated inflammatory markers, and then I'm getting a temporal artery biopsy and managing with corticosteroids if that is the case. So don't forget that you can also get nerve palsies from giant cell arteritis if giant cell arteritis is something that you see more commonly in your side of the world, okay? If you don't see giant cell arteritis ever, maybe keep it at the back of your mind and screen for more common things that you see. But for me, anyway, giant cell arteritis is always one that I cannot forget about. Because the worst thing that can happen is you think this is microvascular and then they lose vision from an arteritic ischemic optic neuropathy, right? So prevent the vision loss from happening and treat the giant cell arteritis sooner rather than later. Okay, so here we are back at the quiz questions. I think the majority of you guys did actually really well even before the presentation. And so they were fairly easy questions, but the oculomotor nerve, A and C are true for this question. So yes, it innervates all of these muscles and also innervates all of this. And so it is not responsible for eyelid closure. We just saw a cranial nerve 3 palsy would result in eyelid closure or ptosis because it innervates the eyelid in terms of opening it, right? And then cranial nerve number 4, it can cause a hypertropia if damaged. So remember the Parkes 3-step test with the which eye is higher. And so it causes a hypertropia here. We talked about how it's one of the unique cranial nerves that exits dorsally from the brainstem, unlike the other cranial nerves. It is easily affected by head trauma because it's got the longest unprotected course out of all the cranial nerves. And so it's not just a short segment, it's a long segment, which is why it is prone to trauma. So that was the answer for this question. And then the abducens nerve, cranial nerve 6, yes, it innervates the lateral rectus. Its nucleus is located in the pons and it's surrounded by fibers of cranial nerve 7. So remember that's cranial nerve 7. So you have to think about it. If you both have a facial palsy and an abduction deficit, you're thinking about something that's happening in the pons because as you saw before in that diagram, the cranial nerve 6 nucleus is wrapped around by the cranial nerve 7 fibers. And then, yes, it needs to communicate to cranial nerve 3 with the nucleus of cranial nerve 3 through the MLF in order for you to do a horizontal gaze properly, because whenever you do a horizontal eye movement, you are activating a lateral rectus and a medial rectus in order to look in that direction. And in order to do that properly and together, there needs to be communication, and that is the MLF. And if you have a lesion in the MLF, then you cannot do that communication properly and you get an internuclear ophthalmoplegia. So B and D are true in this question here. That was a lot, and it was actually a very basic review, so I didn't touch very hard on some of the clinical aspects of it because this was meant to be a beginner's re-review of the anatomy and just to think about basics again. But I guess we will move on to questions now. A question I have here is, have you noticed an increase in cranial nerve palsies post-COVID? If yes, was it temporary or permanent palsy? I don't think I really did notice an increase in cranial nerve palsies post-COVID. But the thing is, I'm also fairly new to practice. And so I did my fellowship during COVID. And as I came into practice, I'm still seeing the most common things as being microvascular and giant cell arteritis as being the most common causes for nerve palsies. There have been a few cases where it resolved on its own and they didn't have any vascular risk factors, even though I looked for them. So, but they weren't immediately after a COVID infection. And so some of these are kind of these idiopathic, maybe they were post-viral and I don't know. So I can't speak to it just because of my lack of experience. And so that's the answer to that question for you. So I'm sorry, I can't answer it for you, but I don't think there's been an increase in cranial nerve palsies post-COVID, but I would have to ask my more experienced colleagues for that. Next question. How long can you delay imaging for pupil sparing cranial nerve 3 palsy? Is there a specific algorithm you utilize? Okay, so I tend to, what I do is if there is a complete pupil sparing cranial nerve 3 palsy, I actually observe them. So I will actually still order the CT-CTA and send it to radiology, but I don't put on it that it's urgent or anything like that. At least they have the requisition, because there's a delay for us here in getting things done, sometimes for imaging. And so I put in the requisition anyway. I observe them once weekly. If they are a very, very reliable patient, I tell them, okay, watch your pupil, watch it, like check it every day, and then call my office if it changes. For the unreliable patient, I check them maybe once a week. I'll bring them back weekly to make sure that the pupil is okay. And if the pupil is okay after like 3 weeks, I'm like, okay, you're probably microvascular. And normally I only feel comfortable doing that if I know and I see their like medical history and it's all, you know, diabetes, poorly controlled, like hypertension, sleep apnea, like the whole shebang. That's the only time where I'm like, okay, you're probably microvascular. Most of the time I'm sending a requisition anyway, and if they start to improve, I tell radiology you can cancel the requisition. If it changes, like if the pupil suddenly becomes involved, I call radiology, I say, I sent a requisition, I need this to be done urgently now. So that's kind of how I do things. It might be different at your institution, but that's how I do it. How long does it take to have aberrant regeneration occur? I'm actually not sure, but I think it's within months. So in trauma and in compressive, you start to get aberrant regeneration within months. The scary thing is when you see a patient for the first time and no one's ever seen them and there's no history of trauma or anything, and they have aberrant regeneration already, you're sending them for imaging right away. If you know that there's been trauma, so say there's a neurosurgical procedure and they cut cranial nerve 3, you sometimes will see aberrant regeneration like within a few months. Around the same timeline as when a microvascular resolves, I would say. I noticed it within like 2 to 3 months when I see these patients in follow-up. So next question. How do I know whether the cranial nerve 3 palsy is partial or complete? Okay, I had the exact same question when I was in fellowship. Partial is when you have only some eye movements involved. So say they can still adduct, but they can't really elevate very well or depress very well, and the eyelid is only partially down. When I think of a complete, I think of like complete, almost complete ptosis, like you only have like a little bit on the bottom left, and the eye is completely down and out. So that's, to me, complete. And so anytime that it's partial, and it's either early and hasn't gone to complete yet, but I don't care, because if I see them at that point, I'm getting neuroimaging because it's partial. I hope that answers your question. How long do you observe or follow up a pupil sparing cranial nerve 3 palsy? Like I said, I see them weekly to make sure that the pupil is not becoming involved. I'll do that for about 3 to 4 weeks. And then by then I'm like, okay, that should be fine. I still tell them, please look at your pupil every day and call me if it gets bigger or changes. But usually by a month, I'm like, okay, I feel a little better about this. Next question. If the patient had acute cranial nerve 6 palsy and decided to give Botox, can we give bilateral Botox or only ipsilateral, and why? So I don't actually have a lot of experience giving Botox, but I know that a lot of people do, just so that you don't get that contraction of the medial rectus while you're waiting for it to resolve. We usually, I think, from what I've seen, it's only given into the medial rectus muscle. and because you don't want to be causing paralysis, more paralysis of the lateral rectus muscle. How's aberrant, Dr. Ahmed asked, how's aberrant regenerations caused? Okay, so I may answer this question a little differently. It will still answer your question though. So the reason you don't get aberrant regeneration in a microvascular nerve palsy is because all the structures of the cranial nerve, all the scaffolding for the nerve is intact, right? It was just ischemic. The nerves had ischemia and then just kind of died, and then they regenerate, but they regenerate and they still have all the scaffolding that's normal for them. So they all go to the correct targets after they regenerate after a microvascular palsy. It takes about 2 to 3 months for this to happen, which is why they recover in 2 to 3 months. So that's for microvascular. The scaffolding and all the architecture around the cranial nerve is intact. The reason you get aberrant regeneration in cases of trauma or in cases of compression of the nerve is because you get destruction of all of that scaffolding and all that architecture for the nerve. So when the nerve is regrowing, it doesn't have any scaffolding or architecture to follow to go to the correct target. And so it just grows, and it grows to abnormal targets that are still in the same area, right? And so that's why you get muscle to muscle. So you get co-contraction of the medial rectus, say, when you're trying to elevate, or you get eyelid retraction. So there's muscle to lid, and sometimes you can get muscle to pupil as well. And so that's why sometimes if you adduct the eye, so you'll see some people who have aberrant regeneration and the pupil gets small, that's aberrant regeneration. And that's why. It's because those specific causes, the trauma and the compression, causes destruction of the supporting surrounding scaffolding and architecture for the nerve itself. And so because of that destruction, it doesn't regrow in the correct direction because it doesn't have anything to grow with, if that makes sense. Wada Mustafa asks, how can you differentiate aberrant regenerations from complete cranial nerve through palsy? So complete cranial nerve through palsy will not move. The eye is down and out. Aberrant regeneration will become confusing for you at first. Like, I remember the first time I saw aberrant regeneration, I was very confused as well. But you differentiate it by examination, basically. So you have to look very closely. You get the patient to move the eyes in all the directions again, and you look very closely, because if there's aberrant regeneration, the eye moves in an unexpected direction from what it's supposed to do. And so rather than being down and out and completely down for the eyelid, if you get them to move and say they adduct the eye and they're trying to adduct the eye, but they can't adduct the eye, but then the eyelid suddenly comes up, then you're suspicious for aberrant regeneration, right? Because the eyelid isn't supposed to come up when you look to the right or something like that, correct? So physical examination, if you have to get them to look multiple times over and over again for you to see it, that is okay too, because what's important is that the patient's getting proper care. So don't be worried about annoying them. Just get them to move the eye over and over and over again. And also just remember, the eyelid comes down when you look downwards. And if you see eyelid retraction when you're looking downwards, that is also aberrant regeneration. Someone asked, can you have a mixed partial third, fourth, and sixth nerve palsy? And how do you check for fourth nerve function in this case? So if you have a mixed third, fourth, and sixth, you're thinking about the cavernous sinus, right? Because that is where things come together. Those 3 nerves are all together in the cavernous sinus. If you're noticing those 3 all together, I don't think you need to clinically try to distinguish how to check for cranial nerve 4, I don't think. What will happen is, if you have a partial third and a sixth, but 4 is spared, you will see the encyclotorsion. In attempted abduction or adduction, I think you will see the encyclotorsion, and that will be all you see, right? Encyclotorsion. Because 3 and 6, so there's no horizontal movement, no real vertical movement, and then if 4 is intact for some reason, you will see encyclotorsion only in that eye. If all of them are involved, then there'll be no movement. They basically have complete ophthalmoplegia, right? Why is cranial nerve 3 the most affected in diabetic patients? That is not my observation. I've seen a variety of cranial nerve 6, 3, and 4 for diabetic patients. And so I'm not sure why, but it does get confusing when a diabetic patient has a microvascular cranial nerve 3 palsy because they're often quite painful for them for some reason. And that sometimes in itself can prompt neuroimaging. So someone asked, I had a case of acute third nerve palsy with severe headache in a young patient with normal MRI and normal MRA, how to proceed further. Again, just go back to your history. That's the best I can do, and then get blood work based on the history. Acute third nerve palsy, are you certain that the MRI is normal and the MRA is normal? Make sure you review the images with radiology. So my only advice for you there is that's how I would proceed if all my investigations have been normal so far. And then I would still follow up with the patient with the acute third nerve palsy to make sure that nothing else has changed. But history, do your blood work, screen for all the other causes, and then make sure that the normal MRI and normal MRA are actually normal. Because in my experience, if someone had an acute third nerve palsy with severe headache, I'm not sure that the reported normal MRI and MRA are actually normal. So always review the images yourself or review the images with a radiologist and comb through them again. Next question, how are palsies cured? So it depends on the etiology, and I would say microvascular nerve palsies just resolve on their own, but the cure for a nerve palsy would be determining what the etiology is and treating the etiology. Another question here is, how do you distinguish a congenital ptosis from pupil-sparing third nerve palsy? So usually congenital ptosis you will know from birth, and so they would have, I think a congenital ptosis will have, the classic, there's fat infiltration, you don't have an eyelid crease, and then, or do you, I don't fully understand the question. Are you asking how you distinguish from congenital ptosis versus a pupil sparing third nerve palsy? Because that's how I'm interpreting the question. Congenital ptosis has a very distinct clinical examination and clinical features, and a pupil sparing third nerve palsy also has a very classic examination. So pupil sparing, you have the eye down and out as well. So you have the extraocular motility issues, and it's not just ptosis. Rim Abdeli asks, in fourth cranial nerve palsy, patients would have discomfort. Would patients have discomfort when reading a book? What are discomforts that patients have with other palsies? So yes, they would have discomfort if they had a fourth nerve palsy trying to read, because your eyes need to encyclotort a little bit when you're reading, say like at this level at near, right? And so if they have a nerve palsy and the eyes excyclotorted, they will have trouble reading. The discomfort that they have is usually because they have double vision at that level. And in other patients, other cranial nerve palsies, basically in abduction deficits, they'll have discomfort or more diplopia looking in that specific direction. So for my patients, usually if they have a left cranial nerve palsy, they find it very difficult trying to drive, because if they need to shoulder check, they see double vision. So that's a discomfort for them. I advise them not to drive anyway, but for some people, if they're trying to drive, that's actually how they noticed the nerve palsy at first, was they noticed double vision when they were shoulder checking. Cranial nerve 3 palsy, normally you don't get any double vision because the eyelid is down. So unless the eyelid starts to come up, if the eyelid is down, it's covering the eye, they don't have double vision, they don't have a ton of discomforts. What are the cranial nerves affected by GCA? So the answer to that is basically any cranial nerve. The cranial nerves have to be supplied by a blood supply, and for a GCA, it's a vasculitis, and so it can affect any of them. What is your protocol for infectious etiology testing, serology or CSF testing? That depends on the history. I start mostly with serology, and so I will start with serology and then go from there. CSF testing, I'll usually consider if we're not getting anything on serology, or there's a suggestion in their blood work that there's something going on, or if they have symptoms like meningitis symptoms, and then I would consider CSF testing, because you need to do a spinal tap at that case anyway, right? What kind of refractive error is caused by a cranial nerve 3 palsy? I don't think there is any kind of refractive error that's caused by a cranial nerve 3 palsy. I think most of the time we're more concerned about their double vision and the ptosis, and making sure that it's not a compressive etiology. Dr. Rahman asks, single test which determines fourth cranial adduction downward, any specific name? Okay. I think you're asking about how to check for cranial nerve 4 in adduction. So usually when we see someone with a cranial nerve 3 palsy, what we'll get them to do is, like, we'll lift the eyelid and everything, and to make sure that cranial nerve 4 is not involved, is we'll get them to abduct the eye, so abduct, so lateral gaze, and then look down, and you should see encyclotorsion of the eye if cranial nerve 4 is intact in that position. Encyclotorsion can sometimes be difficult to see, so the trick there is to look at the blood vessels of the eye and making sure that, you know, they're sort of horizontal and that they move. And so you might need to do it a few times to check in the patient, but it will be there, I promise you. Thank you for all the good questions. I actually have somewhere to be right now, so I will stop here. Thank you for participating and for listening to my lecture, and I will maybe see you next time.